Okay, moving on to injuries that we can see around the pelvis, the hip, and the thigh region. We're going to start off looking predominantly at the bony injuries. And the first thing to remember is the structure, the functional anatomy of the hip region. The hip joint is a typical ball and socket joint. The head of the femur is the rounded ball, and it fits into the acetabulum. The hip joint is inherently stable. It's a very stable structure, predominantly due to the bony architecture, but also as a result of extremely strong capsular and ligamentous structures. There are strong muscles across the hip joint, which are also subject to shrinking and tightening as a result of other secondary pathologies. Ligament injuries are very uncommon at the hip. Capsulitis may develop, but most of the problems that we see around the hip are joint problems or periarticular problems. The pelvis itself is formed by the union of three bones, the two innominate bones and the sacrum. And where we have the three bones that articulate together, they form three joints, the two sacroiliac joints and one symphysis pubis at the front. The whole pelvic ring is extremely stable, and it needs to be for the transfer of weight and load between the lower limb and the rest of the trunk. Stability of these joints is predominantly as a result of the ligamentous arrangement. They are short, tight, and very, very stable ligaments. Stability is reduced, however, in certain conditions, such as pregnancy and some pathological conditions like rheumatoid arthritis or ankylosing spondylitis. Disruption of one joint invariably leads to disruption of a second joint. So one sacroiliac joint may become dysfunctional, which then might put stress on the symphysis pubis or the opposite sacroiliac joint. And disruption of the pelvic ring as a whole invariably will stress at least one of the joints. Bone injuries that we see around the pelvic region include things like bone bruising, avulsion fractures, stress fractures that are often picked up on bone scan, and stable and unstable fractures of the pelvic ring itself. So starting off with some of the smaller bony injuries, bone bruising most commonly occurs in the iliac crest and in the sacrum, and this is only really picked up on MRI and often will resolve itself over a relatively long period of time, but it does resolve itself reasonably well. Avulsion fractures, on the other hand, may occur as a result of violent contraction of muscles. Over here we have an avulsion fracture of the ischial tuberosity, which is as a result of an excessive pull of the hamstring muscles. Here is an avulsion injury of the anterior inferior iliac spine, which is associated with rectus femoris. The anterior superior iliac spine may become avulsed from a violent contraction of sartorius, and the other sites that we see avulsion fractures are the top of the iliac crest when the abdominals pull too hard, or the anterior aspect of the pubis where the adductors pull too hard. Occasionally, we may come across stress fractures in the pelvic region. These are often difficult to diagnose clinically, and invariably require a bone scan to evaluate the extent and site of the actual stress fracture itself. Most commonly, these occur in the pubic rami or the ischial ramus. Fractures of the pelvic ring may be classified as either stable or unstable. Stable fracture of the pelvic ring is where the pelvic ring remains continuous. The patient often complains of a very diffuse and very disabling pain, and diagnosis is made by X-ray. Stable fractures include the avulsion fractures that we described, fractures of a single ramus, either a single pubic ramus or the ischiopubic ramus, or indeed fractures of the acetabulum. And these are usually managed conservatively unless there is extensive disruption or displacement of the bony element, in which case they may require some form of surgical intervention. Here we can see a fracture of the ischial ramus or the ischiopubic ramus, and it's a stable fracture because the superior pubic ramus has remained intact, so the pelvic ring appears normal. These sorts of things, these sorts of injuries will often the individual will come in describing pain on strong contraction of the adductors. The management of a stable fracture is very much dependent on the injury, the stage of healing, and the involvement of other secondary structures. From a rehabilitation point of view, the focus is usually on stability, proprioceptive re-education, and mobilization, maintaining mobility of the hip joint itself and of the spine. Unstable fractures are usually much more serious. These are because of visceral structures close to the fracture site. They often require immediate surgical management or medical management. These sorts of injuries can make these because of the proximity of the viscera, can be life-threatening, and invariably the first line of assessment is an X-ray to evaluate the extent of the injury itself. These are often plated or screwed depending on the fracture, and the post-operative rehabilitation will depend upon the intervention, the stage of healing, and any other complications. Rehabilitation is often very extensive. It's not unusual to see these patients for at least a year. Usually when there's an unstable fracture of the pelvic ring, there's severe trauma has taken place. The most common time we see these unstable fractures are falls from great heights or road traffic accidents. The sacroiliac joint is the two joints made between the sacrum and the ilia. They're inherently stable joints, but one of the problems that occurs with unstable fractures of the pelvic ring or disruption of the pelvic ring is that the sacroiliac joint itself becomes stressed. Excessive movement can subsequently develop in the sacroiliac joint, which in turn may lead to pain and irritation of the periarticular structures. In extreme cases, the sacroiliac joint may become separated, and over here we can see a sacroiliac joint diastasis. A diastasis is where the two bones have been separated to such an extent that there is severe ligamentous damage. So this joint here will remain inherently unstable, and that can often lead to excessive pain. The role of the rehabilitator or the clinician, the physiotherapist, will be to provide stability in this region. Anteriorly, we have the symphysis pubis, and excessive movement at the symphysis pubis can lead to a condition known as osteitis pubis, which is an inflammation of the articular surfaces or the disc that's found between the two pubic bones. This is relatively common in individuals that do lots of twisting and turning activities. So footballers and gymnasts may develop this problem, and it's believed to be as a result of recurrent torsional or tractional stress to this area. The pain that the individual describes is usually dull and poorly localized, but can be reproduced on resisted adduction or passive abduction, which in turn stresses the symphysis pubis. It's often misdiagnosed as a groin strain, but treatment of the adductor muscles themselves often leads to very disappointing results. It's a chronic pathology, and eventually it may lead to secondary problems such as ligamentous instability. An X-ray may lead to disruption or sclerotic changes in the pubis itself. So an X-ray is often quite a useful diagnostic tool. In extreme cases, we can see a diastasis of the symphysis pubis. Okay, and this can occur as a result of a major trauma or recurrent minor trauma or relatively minor trauma on tissues that have been devitalized. So somebody with a pubis osteitis may go on to develop a symphysis pubis diastasis. The other time we see symphysis pubis diastasis is in the late stages of pregnancy, which occurs to allow for the birth of the baby, but not under normal circumstances the symphysis pubis should tighten up again. Here is the symphysis pubis. This is an X-ray of the pelvis. There's the symphysis pubis down there, and this bottom X-ray here shows a clear symphysis pubis diastasis, a gap that is way too wide for a normal symphysis pubis. The separation may be palpable, and an X-ray is invariably required to confirm this diagnosis. Occasionally we may come across individuals who have dislocated the hip. Posterior dislocations of the hip are usually associated with fractures of the posterior acetabulum, and the classic time we see these are dashboard injuries, where somebody has run into somebody driving a car has run into an object, the car has suddenly stopped, and they've slid forward, and their knee has hit the dashboard. The femur is then driven posteriorly out of the back of the acetabulum itself. These individuals are often taken to hospital, and they're managed by traction. They're put onto bed rest and tractioned for anywhere up to 3 months, depending on the extent of the injury. As a result of this extended period of bed rest, there is a significant loss of strength and loss of mobility. And the role of the rehabilitation specialist is to increase stability in the early phases, but eventually focus on the active range of movement. Full active range of movement must be regained before any form of return to sport is allowed. Otherwise, this ends up stressing the hip joint unduly. Bony injuries within the pelvis usually require significantly high load, high stress. So invariably they're high impact or traumatic injuries. The danger with pelvic injuries, bony injuries around the pelvis, is any associated medical problems that may occur. The joints of the pelvis are inherently stable, but instability can develop as a result of high stresses, either macro trauma, so sudden trauma, or recurrent micro trauma, instability invariably leads to a significant amount of pain and subsequent dysfunction.